So Don, welcome to the 2012 Nuffield Trust Annual Summit.
Nice to be here.
Great to have you. You obviously have got a unique perspective on what's happening to healthcare reform in the United States, but as you've probably also seen, there's a lot of controversy here as well. Why is health reform so controversial on both sides of the Atlantic?
We care about it so much. I think it's an interesting intersection of the deepest self-interest of individuals, to be healthy and well and free of worry, and enormous economic stakes and pressure. A status quo in the United States that's spending, 18% of our gross domestic product now, and everybody's involved. You can do hardly anything at all in public policy and healthcare without provoking reactions from professions, from patients, from economic stakeholders. We're all in it.
You just had this intense experience running Medicare and Medicaid for the United States after 20 years of campaigning for quality improvement. What do you know now as a result of that experience that you didn't know 18 months ago?
Oh, it was an amazing experience. I was put in charge of Medicare and Medicaid and the Children's Health Insurance Program. That's a total of over $800 billion of expenditure, and on top of that, the agency that I ran, the Centers for Medicare and Medicaid Services, had responsibility for implementing about 60 or 70% of the provisions of the new healthcare law in the United States, the Affordable Care Act. So it could not have been a more intense episode in my life, or more exciting in terms of the learnings that went on. I learned a lot about both the leverage and the limits of government. I was stunned, moved by the daily challenges I was presented with to make decisions about details of regulation that would affect literally millions of people. And for my whole career in improvement, probably the climactic issue has been scale. How do you take the great things that we know that can be done in healthcare and bring them to large scale? And I saw the power in proper government action for really helping accelerate progress toward the kind of care system we want. I was constantly mindful of the sharp end of care, which is that in the end, what was going to get better could happen only through individual deeds and contextually adapted changes, community by community, location by location, even provider by provider.
Even in a government-funded single-payer system like the British National Health Service, you've got these large variations that exist around clinical quality. So, for example, the BMJ published some data a few months back showing that perhaps 24,000 people die from diabetes-related complications that could have been avoided if their care had been properly managed. There's a twofold variation in the management of heart disease in general practice. We know about these variations. What can really be done in practice to deal with them?
This comes from the legacy of almost a romantic view of medical care as kind of an individual, heroic enterprise, the doctor, the patient together solving the problem, and in a social contract in which the public trusts the profession. I think as we move toward an era where things are more transparent, almost everything that happens will be good, that the people that give care can know that they're differing from each other and inquire about why and seek relationships between outcomes and the practices they engage in. And the public and the payers can make better judgments about exactly what they want to buy and from whom. So I think that's a major shift.
One of the areas that is an intangible in healthcare but is so important for patients is compassion and dignity. And particularly as the proportion of people using hospital services who are very elderly has gone up. In Britain, the numbers of people aged 85 and over has doubled in the last 15 years or so. There's been real concerns about whether or not the NHS is treating older patients with dignity and compassion. What in practice do you think can be done to improve that state of affairs?
Two things at least. One is to attend to the definition of excellence itself, very self-consciously, professions, the public, all of us together, and to realize that to to define the excellence of care in terms of what is done is less powerful than to define it in terms of what is achieved. And what we seek in healthcare is relief of discomfort, lengthening life, and the preservation of human dignity and spirit. We have confused for decades excellence with the number of things done. The more done, the better the care. That's not true at all. The more the patient is feeling what the patient wants to feel, the better the care. The other change that's crucial, I think maybe even possibly more important in the UK than in the US, I'm not sure about this, I would say, I call it to put the patient in the room, put the person in the room. I've never seen a limit to the value of bringing patients and families into the conversation at all levels of the design, execution, judgment, and conduct of care. If we really listen carefully and help people speak up, the care will get better and more dignified.
The corollary of that is that there probably are going to be real changes in technology that affect healthcare delivery over the course of the next 10 or 20 years. We're going to see that with telemonitoring, some of the new genetic testing and therapies, a whole range of innovation that's likely to have potentially quite powerful impacts, hopefully positive. What do you see the most profound of those as likely to be over the course of the next decade or two?
I'm not personally technophilic. I mean, I don't love technologies for their own sake, but I'll tell you, in Washington, in the year and a half that I got to do this job, I had the chance to travel around the country and see innovations. And the most exciting ones I saw are in this space, the ability to project knowledge in all sorts of media that are so far from the concept that the way to project knowledge is to meet with a doctor in her office or his office. In Alaska, I saw a system that the Alaska Native Health System is using to do metrics of patients out in tiny little Eskimo villages and transport that data back to the center where the most skilled experts can look at it and give the terrific judgment, doing away with the need for travel, doing away with waiting times. I think we're at the threshold of a revolution in which the concept that you have to sit together face to face in a conversation, and that's the only way to get care. It's just not true. It's valuable, but it's not true.
What do these potential changes mean for the shape of the hospital of the future? 20 years' time, how will hospitals differ from what their scope of services are now?
How they will differ, I don't know, and that's a political question. How they should differ, I do. Mm-hmm. I don't know about Britain, but I know in the US, healthcare has grown up around the hospital as the center, at least since the 1940s and 1950s. The proper place for a person to be is home. The proper number of days in the hospital is 0. You know, the best bed is an empty one. And if we have a healthcare economy which is rewarding hospitals to be full, which is confusing volume with value, which is confusing technology, interventional technology with health, we're dead wrong. So I think that will change. I hope that will change because we have tremendous opportunities to stay well and to help each other stay well. So what does this mean for hospitals? They have to have a different business model. They have to begin to understand how they could produce beds by emptying them. We have new models of integrated payment in our new law, the Affordable Care Act. We have accountable care organizations and medical homes and health homes and community-based care transitions, and these are all payment models intending to change the incentive system so that everyone is happier when the patient's home.
There are obviously huge financial pressures that are going to be bearing down on the British healthcare system over the course, not just of the next several years, but probably beyond that. Mm-hmm. On the sort of optimism, pessimism scale, where are you about the ability of this healthcare system and others to adapt and prosper in these straitened financial times?
Struggling to be optimistic. Technically, I'm bullish. I mean, I think from 30 years of work on improvement of care, seeing great practices, productivity gains of the kinds that are needed are accessible, that we can do it. We can probably double what we need. I mean, I think it's, healthcare is really broken now and it could be fixed well. The politics are just terrible here, right? I mean, not just in the UK, but in the US as well, because the vested interests in the current configuration of the flow of a large sector of the economy are very, very strong, and people are arguing strongly that they should be allowed and encouraged and rewarded even more to do what they do now instead of what they need to do in the future. Whether we'll have the political courage to see through that and get into the next phase of healthcare, I don't know. Can we do it technically? No question at all. I've heard the data about the aging of society, the growth of effective technologies, all cost drivers. A serious endeavor, social endeavor, to remove waste from care and orient it toward health could pay for that twice. So we can do it if we want.
Don Berwick, thank you very much.
Takes a lot of time.